Hello and welcome to Group 5's presentation on physician-assisted suicide. So what exactly is physician-assisted suicide? One of the most widely accepted legal definitions of physician-assisted suicide is that it is the voluntary termination of one's own life with the direct or indirect assistance of a physician. In most cases, it is brought about by a certain mixture of prescription drugs or with a lethal overdose of another, all with the oversight of a physician. It generally becomes a consideration for those with terminal debilitating diseases, such as some forms of cancer and amyotrophic lateral sclerosis, ALS, among others. Due to the aggressive nature of some end-stage treatments, patients may choose physician-assisted suicide to preserve their remaining quality of life and time with loved ones. Essentially, it allows for death with dignity. What is the public opinion of physician-assisted suicide? Despite its inherently divisive nature, a 2017 Gallup poll estimates that 73% of the population supports the issue. Breaking this down along ideological lines, a great majority support it, with 89% of liberals and 60% of conservatives backing it. Moderates fall in the middle between them at about 79%. And even among those who attend church weekly, the demographic most morally opposed to it, 55% of people still support this notion. Where you really see these differing views and ideologies play out is within its terminology. Those who champion the idea of physician-assisted suicide generally refer to it as the right to die, death with dignity, physician-assisted death, and generally assisted death. The groups most likely against it refer to it as physician-assisted homicide, mercy killing, and just plain homicide.
Throughout the years, there have been numerous legal implications pertaining to the topic of physician-assisted suicide. In 1997, the U.S. Supreme Court ruled on this topic and declared that legalizing or criminalizing physician-assisted suicide was a matter of states' rights. So it's up to the states to decide for themselves whether or not they would legalize physician-assisted suicide. 3 years prior to this ruling, in 1994, Oregon was the first state to legalize physician-assisted suicide. Following Oregon in 2008 was Washington, Vermont, California, Colorado, the Districts of Columbia, and Hawaii who legalized physician-assisted suicide. And then in 2009, Montana's Supreme Court legalized physician-assisted dying. The states who have legalized physician-assisted suicide have special requirements to do so. The patient must have 6 months or less to live. The patient must also have 2 oral requests from a physician at least 15 days apart from each other, and 1 written request. The patient must also be at least 18 years of age. There are 36 states that now prohibit physician-assisted suicide. And in many of these states, this can be a crime or punishment, and they can include manslaughter, murder, felony, fines, or imprisonment. There are also states that have no specific laws on this practice, and they include Nevada, North Carolina, Utah, and Wyoming.
A timeline of important events in legislature involving physician-assisted suicide. The year 1906 saw the first drafted bill to legalize euthanasia, both voluntary and involuntary, in the United States. Although it was the first of its kind to be seen in the U.S., it failed quickly because of the poor written structure and the controversial topic of involuntary euthanasia, which stemmed a lot of ethical debate in the medical community. In 1938, the first Society for Euthanasia was founded in New York City, and it was called the Euthanasia Society of America. The ESA was important for the introduction of the first living will in 1967, which was the first introduction of an advance directive in the United States, allowing for patients to outline their preferences for treatment during a terminal illness, which included their refusal of life-sustaining treatment during the terminal illness. By 1976, because of the introduction of the living will and other advance directives, a majority of the states in the United States had some type of policy to recognize advance directives. In 1973, the American Hospital Association created the Universal Patient Bill of Rights, which gave structure and requirements to facilities to develop their own individual patient's bill of rights. This was based around the patient's right to be informed of all treatment options and related information in order to give a consent to any type of treatment or to their right to refuse treatment. In 1974, the first hospice care facility in the United States was opened. It was located in Branford, Connecticut, and it specialized in care for the terminally ill. It was introduced by Dame Saunders, who founded St. Christopher's Hospice in the United Kingdom, and brought the idea of hospice care over with her when she came to visit Yale University. The year 1990 saw a radical change in the evolution of legislation within the United States. Jack Kevorkian sparked the need to set legislation following his involvement in the euthanization of Janet Atkins and dozens of other terminally ill patients. The lack of legal action available against Kevorkian's involvement made it clear that there was a need to establish a clear legal stance on the topic of physician-assisted suicide and euthanasia within the country. By 1994, every state in the United States recognized and possessed some type of advanced care directive protocol. But more importantly, in 1994, the first Death with Dignity Act was approved in Oregon. It was called Measure 16, and it was the first piece of legislation passed that would legalize physician-assisted suicide. However, the U.S. District Court barred this piece from taking effect, and this lasted until 1997. In 1997, Oregon's Death with Dignity Act was finally passed and implemented, and was the first piece of legislation legalizing physician-assisted suicide within the United States. Following Oregon's precedents, in 2008, Washington State passes the Washington Death with Dignity Act based on the Oregon legislation that was passed in 1997. Following suit, the state of Vermont passed their own piece of legislation called the Patient Choice and Control at the End of Life Act in 2013, followed by California passing its End of Life Options Act in 2015, and Colorado and Washington, D.C. also passing their End of Life Choices Acts in 2016. Hawaii is the last state to pass a piece of legislation legalizing physician-assisted suicide with its Our Care, Our Choice Act in 2018, taking effect in the year of 2019. All of these states, with their passing of these pieces of legislation, have legalized physician-assisted suicide or physician-assisted death to mentally competent patients to receive prescriptions to end their life if they are currently dealing with a terminal illness.
When discussing physician-assisted suicide, it is important to talk about the ethical implications. How is the patient's quality of life affected by their illness or disease? Can they live a meaningful life with it? If not, is it acceptable to continue to make the patient suffer through their pain as their symptoms worsen? Soon the patient may not be able to make any choices for themselves. They can lose their autonomy as they progress through the stages of the illness. Additionally, doctors have a reluctance in taking a patient's life. For some, it's a religious obligation, and for other doctors, it's the belief that physician-assisted suicide goes against their core mantra of first do no harm.
State-by-state statistics show that between the years 1998 to 2017, 4,249 prescriptions were written for physician-assisted drugs, and 66.3% of patients use these drugs to end their lives. Of these statistics, 49.3% were female and 50.7% were male, 94.2% were white, 47.7% had college degrees, and majority of these people were between the ages 69 to 89 years old, and lastly, 63.1% had cancer. These statistics are important because they can infer whether demographics or type of diagnosis might determine whether or not a patient chooses physician-assisted suicide.
Now, there are a variety of court cases in the US that involve euthanasia and physician assisted suicide, and these date back to the 1970s. And a lot of these landmark rulings have largely dictated the current political and legal standing around PAS, as well as the overall public sentiment for the topic. And so the two most significant proceedings that I chose to look at were Washington v. Glucksberg and Gonzalez v. Oregon. And both of these really fought to legalize and legitimize PAS under state law. So in Washington v. Glucksberg in 1997, Harold Glucksberg and three other practicing physicians from Washington State, Abigail Halperin, Thomas Preston, and Peter Shallett, challenged the state's ban on PAS. So utilizing cases such as Planned Parenthood v. Casey and Cruzan v. Director of Missouri Department of Health, the plaintiffs made the argument that under the 14th Amendment, a mentally competent and terminally ill adult should have the choice to commit PAS. So the district court ruled in favor of the plaintiffs, stating that the ban on PAS places an undue burden on the exercise of that constitutionally protected liberty interest. And what's interesting about this is the Court of Appeals, the Ninth Circuit, later affirmed this ruling, stating that the state's assisted suicide ban was unconstitutional as it applied to terminally ill, competent adults. And so after these rulings, the Supreme Court granted the state of Washington certiorari, which is essentially an order by which a higher court reviews a decision of a lower court, and they unanimously reversed the decision, agreeing that the ban on PAS did not violate the 14th Amendment. So overall, this was a very interesting court case that largely dictated kind of the environment and current political and legal standing surrounding PAS in Washington and also nationally. And so when we look at Gonzalez v. Oregon, we kind of need to take a step back and look at the Death with Dignity Act passed in 1994 by the state of Oregon that actually permitted terminally ill patients to be prescribed PAS by their physicians. So this law that allowed the prescription of lethal doses of controlled substances was brought into question in 2001 by the U.S. Attorney General, John Ashcroft. And Ashcroft declared that this act was in violation of the rules put in place by the Controlled Substances Act of 1970. He went on to threaten these physicians who had practiced PAS under state law legally, claiming that he would revoke their licenses to practice medicine. And so this went up to the Supreme Court, and in a 6-3 majority delivered by Justice Anthony Kennedy, the court held that the CSA, or Controlled Substances Act, was put in place to prevent physicians from illegally dealing drugs, and that it did not define any state's medical practice standards. So beyond this, the ruling held that the Attorney General had no right to ban the use of controlled substances for physicians-assisted suicide as well. And this is stated in the second page of the ruling, where it quotes, "The CSA, Controlled Substances Act, does not allow the Attorney General to prohibit doctors from prescribing related drugs for use in physician-assisted suicide under state law permitting the procedure." So this was certainly a landmark victory for the state of Oregon that further legitimized and protected the rights of those wishing to go through with PAS and also those physicians who were practicing it. So I chose to look at a clinical review entitled Attitudes and Practices of Euthanasia and Physician-Assisted Suicide in the United States, Canada, and Europe. And within that, I chose to focus on aspects of the review that touched on the United States. And I did find it useful to research the international environment as well, because I noticed that there were a lot of similarities, but also some clear differences in practices and overall sentiment regarding the topic. And so this review was conducted by 3 PhDs, an MD, and then also a fourth individual by the Medical Ethics and Health Policy Department at the University of Pennsylvania. And so the purpose of this review is to examine the legal status of euthanasia and physician-assisted suicide, along with the current standards and opinions regarding the subject. And so the review looked at polling data and published surveys of the public and physicians regarding PAS, It also looked at official state and country databases, interview studies with physicians, and death certificate studies as well. And so these were reviewed between 1947 and 2016. So it was quite a comprehensive set of data that they took into consideration when deriving this review. And so one thing that the authors noted, and I think this is oftentimes seen in survey data and other public opinion polls and things like that, is that the results vary greatly due to factors such as prompt wording, sample sizes, and also non-randomization. But the key takeaway that they found was that public opinion has fluctuated significantly over time regarding physician-assisted suicide. So back in 1947, for instance, in the US, 37% of the public agreed that PAS should be legal, whereas in 2005, it hiked all the way up to 75%. It has now come down to 64% in 2012, but as you can see from an overall perspective, it has increased significantly over the last 50, 60 years. And so one survey by Medscape found that U.S. physicians were most supportive of PAS when looking at all of the countries together that they analyzed in this review, and that 54% agreed that it should be legal. But again, these surveys can have biases or limitations that may misrepresent the actual numbers. So currently, PAS excluding euthanasia is legal in seven U.S. states: California, Colorado, Hawaii, Oregon, Vermont, and Washington. It's also legal in the District of Columbia. And the frequency of these deaths increased after legalization, but between 0.3% and 4.5% of all deaths are reported as euthanasia or physician-assisted suicide in the jurisdictions where it's legal. So it's certainly not making up a large percentage of the overall death rate since it's been legalized in these states. And also, something interesting to note is that more than 70% of cases involved were patients with cancer, right? So it's most often oncologists and patients who are terminally ill with cancer that are requesting to have PAS. And so in the United States, less than 20% of physicians report requests for euthanasia or PAS, and less than 5% of those actually perform PAS. So to provide some context, in Oregon and Washington State, less than 1% of licensed physicians actually write prescriptions for PAS every year. So it's a very small percentage of physicians who are actually willing to take on this type of procedure. And I think a lot of that has to do with ethical reasons, also religious reasons, or whatever personal reasons, because it is such a contentious topic. But that being said, it still seems that there is a majority support from physicians that agree that PAS should be legal. So as physician-assisted suicide is increasingly becoming legalized and accepted by society, the requests remain relatively rare, and like I said, primarily involve patients with cancer. And existing data doesn't indicate widespread abuse of these practices, which is really important. So though this is a relatively new procedure with limited data, it seems as though there's no substantial indications of abuse, which is vital to its legitimacy moving forward. And I think it'll be really interesting to see kind of how this topic plays out over the next coming decades and whether or not PAS becomes a legalized nationwide or not. And so in closing, I think reviews like this are important to analyze and also continually perform to gauge where PAS is headed and to predict the overall future outcomes for this procedure moving forward.
In conclusion, here's where we project physician-assisted suicide will end up in the next few years. Currently, nearly 3/4 of the population supports physician-assisted suicide and the right to die. The legality of euthanasia and physician-assisted suicide has been growing in recent years, with various state court cases ensuing since the 90s that have been arguing for its practice. Based on this, the possible outcome that we predict is the slow but sure rise in the legalization of the practice state and nationwide.